Now to listen to our chief guest. I welcome Sir Carsten Engel, who is the CEO of ISQA, the International Society for Quality in Healthcare. Sir has been the CEO of ISQA since the year 2021. To his multiple credits, one important one is that he developed, implemented, and managed the National Danish Accreditation Program. Sir Carsten Engel, sir, we are now ready to stand on your shoulders and look at what accreditation looks in the future. Over to you.
Thank you. Very kind welcoming words, and good afternoon to all of you. And thank you for the invitation to speak to you today on the occasion of the World Accreditation Day. As you know, accreditation is an important part of ISQA's portfolio delivered by a separate legal entity, the ISQA EEA. We have been accrediting healthcare accreditors for 25 years, and presently more than 70 organizations from 37 countries, regions have at least one product with us, and several of these are based in India. We believe that accreditation has made a substantial difference for the healthcare provider organizations that have embarked on the accreditation journey. We would never claim that accreditation is the only road towards excellence, and certainly not that accreditation is a magic bullet that will solve all your problems. What accreditation is a tool. The accreditation, and in particular the top management of the accreditation, should be aware that the value of accreditation is not that it may generate a certificate with a golden seal. If you get a certificate, celebrate, of course, but you should be aware that the true value is that accreditation takes you on an improvement journey. The standards guide you, and the external evaluation adds to your insight into how your organization works and how it might improve. One piece of advice: focus on the intention, the spirit, the purpose of the standards. Don't over-focus on the measurable elements, criteria, or indicators. They are an indispensable tool as they frame and give structure to the external survey, but much bureaucracy and red tape is generated if the hospital takes the approach that it must ensure it advances, and each and every measurable element is met to the final letter. It will take some courage from hospital management, but by focusing on the intentions behind the standards, the hospital will, that's my firm belief, find that most of the criteria will be met, and should accept that the surveyors point out some areas for improvement, and they should view this as a positive outcome of the survey, one of the things the survey is about. This approach will, of course, require that the surveyors and those who make the final award decisions also assess in the spirit of meeting the intentions and generating the expected outcome, rather than compliance to the last letter. There can be no doubt that there's a power in accreditation, and I believe that the mechanism is not very complicated. If I tell you that I expect you to meet such and such requirements, if you know that I will come and assess whether you actually do, if the outcome of the assessment matters to you, be it in terms of financial benefits, market benefits, reputation, or because you believe that it will improve your organization, then you will make efforts to be able to demonstrate to me that you are in compliance with my requirements. However, we are not interested in merely formal demonstration of compliance. We're interested in real, continuous, and sustainable improvement. Research indicates that accreditation will be able to improve healthcare delivery if there's coherence, alignment between accreditation and the organization's beliefs, context, and model of service delivery. In other words, accreditation addresses what you want to do in a way that fits into your situation. There must be organizational buy-in, acceptance from managers at all levels and professionals, and there must be organizational action in response to observations, feedback, or self-reflection resulting from the accreditation process. In other words, you have the will and the resources to do something about it. Accreditation can't remain static for 25 years. We have become aware that healthcare is a highly complex system perhaps the most complex system that ever was created by humans. This, and in particular its implications, was not well known 25 years ago. In a complex system, cross-couplings and feedback loops make it hard to predict precisely the effect of a given action, and therefore also makes it impossible to reduce management to creating a manual, an algorithm that encompasses everything that could happen and provide rules on how to act in every conceivable situation. So this in itself means that managing by process compliance is not feasible. We must move towards a more outcome-oriented approach, and I'll come back to that. Furthermore, healthcare is an open system that interacts with its environment, and we usually can't control what enters the system from outside. A complex system, a hospital, can't be designed like a machine to a set of specifications, such as accreditation standards specifying structures and processes, and once designed, be expected to work day in and day out, delivering what we want it to do. Standards do, however, reduce complexity by creating some order and predictability, and a little bit more than that, as I will show you in a moment. So we can't hope to design a complex system that works like an automaton by pre-designed rules. What we can hope for is to make the system perform in a resilient manner. By this, I mean a system that can sustain required operations under both expected and unexpected conditions by adjusting its functioning prior to, during, or following events. Adjustments are needed to meet crises, big crises, but also to cope with the bumps and variations as they happen all the time in everyday practice. We can't design the resilience by creating structures only. Resilience is functional, it's not structural. Holnail explains the basis for resilient performance like this. The cycle applies to individual patient care, but it also applies to management on the floor level and on the hospital level. We must anticipate what if things are progressing as expected, or if you need to adjust or intervene. You must have a set of actions, a toolbox if you like, from which to build your response. And you must have the insight to learn from your experience to improve your skills and understanding. This requires professional skills. It is vastly enhanced if professionals work as well-functioning multi-professional teams, including patients and families. But it also requires a system that not only allows, but also facilitates it to happen. Accreditation of the future must be able to support this. There are tools by which you can assess your organization's capacity to perform in a resilient way, but I'll just mention a few important points about accreditation. First, you should have a good set of standard operating procedures to guide your responses. This is the toolbox you need to build your response. If possible, rarely used procedures should be rehearsed, and simulations may be used for relevant scenarios, and is, by the way, also a very good way to train team performance. The number of skill mix of professionals should be appropriate for the task, and this should be in the accreditation standards. It is there. Effort should be made to train and develop team competencies, and there should be time for reflecting and learning, which needs not always occur in a classroom setting. Opportunities for learning should be provided as a part of the daily routines, like little huddles and debriefs or whatever. Accreditation can require all of this, and the benefits of including these things in accreditation standards are that it brings them on the agenda. Expectations can be expressed and communicated clearly. Standards can be written in a way that guides implementation. The assessment process will inform you whether they are met and give you ideas on how to improve if they're not, and it's a mechanism to hold leadership accountable. Accreditation should be aligned with the picture we have on how to improve performance. The simple model here is based on the model for improvement that many of you will be familiar with. Where do we want to be? Are we there now? If yes, don't assume that everything remains fine. You will need to anticipate, monitor, respond. But don't, on the other hand, fall into the trap of creating an evaluation machine where you believe that you should document, tally, and review proof for compliance all across the system all the time. If the answer to "are you there now" is no, then what might you do to get there, and how would you monitor performance and progress? And this is, of course, repeated in a cyclic manner. Accreditation can clearly support the what and the check, but it can also support the how by embedding guidance into the standards and by the dialogue you will have when working with the standards. And check is not only about reviewing the outcome, but also about understanding how and why the outcome is generated, why it is what it is. And this is, of course, essential if you want to improve it. And here, the qualitative information collected in the dialogues framed by the standards, whether they're internally in the hospital or with the external servers, they're an invaluable tool to increase your insight. Accreditation and the way in which accreditation is used, not the least, it's a tool. It's not just a tool, it's also the use of the tool that determines what comes out of it. It must be based on several pillars. Of course, it must be based on healthcare science, the thing, what we want to offer to patients. But it must also be based on implementation science, how we make the thing happen. And it must be based on the system science, a systems perspective. We must appreciate that the thing might have unexpected consequences for other things in a complex system, and not always as easy to implement as one would have thought and hoped. So until now, I have talked about the framework, the prerequisites, and let's now take a closer look at what I mean by an outcome-oriented approach. In resilience science, we talk about work as imagined and work as done. Work as imagined has a formal component, what's written down as policies and procedure, and that can, of course, be assessed by document review. But there's also the work of as imagined as it is in the minds of the staff. How the staff understand what they should do and why they should do it. This is important and can be explored by interviews with staff. Most important is, of course, work as done, what actually happens, and we have several ways of assessing this: interviews with patients and families, chart reviews, observations, and data. And output, the services delivery, and the outcome, the impact, all can be assessed by data as well. And accreditation should address all of these components, and especially the link between, or the gap between work as imagined and work as done, that may give important insight into how the system works, but of course also the link between work as done and the output and outcome. But for at the end of the day, work as done should not be judged by compliance with standards, but by whether it is likely to generate the outcome and the impact we want it to generate. This is to remind you that accreditation, in addition to assessing care delivery, also assesses how care delivery is governed and managed. And this includes the classical components: governance, management, risk management, quality improvement. But nowadays, healthcare quality also means addressing the environmental and social impact of the healthcare system. Healthcare is one of the major carbon emitters, so this is a major challenge of today, and we can't, so this must be addressed. In addition, we can't expect a system to deliver good care unless it takes care of the workers in it. And finally, digital health, including but not limited to the use of AI, is there and needs to be considered. It's causing a major paradigm shift for the healthcare delivery, and accreditation must be able to support and guide this shift. Care delivery and governance and management issues are all addressed in the ISCO principles for the development of healthcare and social care standards, and the 3 emerging issues will be addressed in the upcoming 6th edition that's in process now. The ISCO principles are a framework for the development of accreditation standards. We believe that one size does not fit all. It's not possible, not even desirable, to try to develop one set of standards that at the same time can be applied to all types of countries, cultures, and healthcare setting, and also at the same time provide guidance that's contextual, relevance, and talks to the people that actually provide care for others. And finally, to summarize a few points on this slide, we need to move from accreditation 1.0 towards accreditation 2.0. Standards should not be a compilation of criteria that characterizes a well-performing organization, but should set an agenda to achieve a defined aim. I actually sometimes think that when the approach by a hospital to the standard should not be to say, what shall we do to meet standard 1, 2, 3, and etc. The accreditation standards will help the hospitals to set their leadership agenda, and they must be sure that the leadership agenda covers what's in the accreditation standards, but the approach should then be, how can the standards support our work with agenda item 1, 2, 3, and etc. Onto my table here, we should, in addition to specific requirements for certain structures and processes, provide guidance for the design of structures and processes, allowing for different approaches and guidance for leading complex systems. Examination of processes for compliance with requirements will be played down, while processes will instead be examined to understand why outcomes are as they are. Judgment will be based less on process compliance and more on outcomes, and reporting will focus on mechanisms rather than on mere tick box style compliance. Instead of telling you what you should do, standards and the entire accreditation process will help you achieve what you want to achieve. The classical survey methodology will continue to be used, but more data sources, including quantitative data from a broad range of resources, will contribute to the assessment, and patients and families will have an important role in the process as well. I'll add to this that accreditation must be as easy as possible. Both the standards themselves, the assessment process, and the way they are received and used by healthcare providers must move away from accreditation as a project, an event you prepare for. It's a tool you use and an assessment that informs you. So with this, I'll say thank you for your attention, and I look forward to meeting those of you who will join us in Istanbul. I will stop sharing now.
Thank you, Dr. Carsten Engel. It was really wonderful listening to you today evening. Thank you so much for your time. And the 3 points which caught my attention when I was thinking about the accreditation of future. Number 1, the staff, we will not be instructing them what they should do. Instead, help them achieve what they want in terms of improving patient safety and quality care, 1. Second is, there will be a role for patients and patients' families to have a say in the whole process. And number 3, and the most important, there will be a mechanism to make leadership accountable. So thank you, sir, once again. And I hope that you are staying back with us to answer any questions at the end. Thank you so much. And that brings us to the second last portion of our wonderful webinar today. And I'm so thankful that most of you are still with us.